Thank you, Tom, for the introduction, and thank you to Evidence Synthesis Ireland for the opportunity given to Claire and I to present to you the Priority 3 project. During the course of the next 15 or 20 minutes, we're going to describe what the Priority 3 project is, put that in the context of what Priority 1 and 2 were, describe who was involved in Priority 3, the need for Priority 3, and then go into a little bit more detail around the processes and the conduct of Priority 3 and share the results with you. To start, the Priority 3 is a priority setting partnership that has identified priorities for future research around how we plan, do, and share the results of rapid reviews in the context of healthcare. We're very grateful to our funders, the Health Research Board and the Health and Social Care Division of the Public Health Agency of Northern Ireland, who funded the Priority 3 project within Evidence Synthesis Ireland. The study was conducted in collaboration with the James Lind Alliance, which is a UK-based initiative set up in 2004, and it brings multiple stakeholders together in a transparent and evidence-based priority setting partnership to identify and prioritise the most important evidence uncertainties or unanswered questions about specific topics. As hinted by the name, this priority setting partnership is the third in the priority series. The Priority 1 and 2 priority setting partnerships were focused on uncertainties about how we recruit and retain participants in randomized trials. Ordinarily, James Lind Alliance priority setting partnerships have focused on health conditions or settings, such as asthma, Parkinson's, or for example, emergency medicine. Priority 1, 2, and 3 are different because they identify and prioritize uncertainties about research methods, that is, about how we plan, do and share research. To do this, we need to include a different variety of stakeholders, for example, researchers. And this is why we say that the James Lind Alliance approach has been modified slightly for the priority projects. We expect that most of the audience will understand and appreciate the importance of rapid reviews in informing healthcare decisions. And indeed, there has been a substantial increase in the demand for rapid reviews of synthesized evidence. And that's been exacerbated substantially over the last 2 years since the beginning of the COVID-19 pandemic. However, despite the increased demand for and indeed the production of rapid reviews, there are still many uncertainties and unanswered questions about that inform decisions we might take about how we plan, do, and share the results of rapid reviews. Priority 3 has been led by an international steering group, and we're also very fortunate to have had Covident as our collaborator. The name of each of the steering group members is listed on this slide, and we have within the group overall 5 patient and public partners, 6 researchers, 6 clinician researchers, 4 policymakers, and 3 funders. There was considerable impactful patient and public partner involvement in the project. Evidence Synthesis Ireland are planning additional webinars on the Priority 3 project that will include additional detail on the impact of this patient and public involvement on the project. But I think it's reasonable to say that the project provided a means or a vehicle for authentic or genuine conversations to happen and change to occur. And this led to new directions for the project based on the PPI contributions. Coincidentally, last night, I came across the recent paper by Knowles et al., which I think helps summarize the impact of that patient and partner involvement on the Priority 3 project. And to summarize, the initial direction without PPI was different to the direction that we actually took. And we feel our project is better because of that. I'll give you one example of the influence of our patient and public partners on the project in my next slide, and I'll leave any additional discussion around the impact of PPI for the future webinars I mentioned. So one concrete example of the impact is the development of a suite of definitions for use throughout the project and the development of an animation for the Priority 3 project. During the steering group meetings, it became apparent that it was necessary to develop definitions for rapid reviews, for evidence synthesis, for systematic reviews and healthcare to be developed for use throughout the study to aid recruitment in some ways, but absolutely to provide clarity around what we were asking participants to get involved in. The patient and public partners identified the need for such resources and contributed substantially to their development, along with the members of the steering group who were experts in the methodology of rapid reviews. I think it's fair to say, and the steering group would probably agree, that this process slowed the work of the Priority 3 project, particularly in the early stages. But that was really critical work to do that ensured that the project we were undertaking was as understandable to different stakeholders as was possible. And our project is better because of it. The definitions we developed and a link to the animation are available on the Priority 3 webpage for you to review it in your own time. And that's available on the Evidence Synthesis Ireland website. The definition that you see on the slide here is what we use to describe rapid reviews. And this definition has been adapted from that provided by the Cochrane Rapid Review Methods Group. And I'll give you a moment to read that yourselves. And as you do so, I'd like to hand over to my colleague, Claire.
Thanks, Declan. So I'm going to talk through what we did in Priority 3. And although there are 7 stages of a James Lind Alliance PSP that range from forming the steering group right through to the dissemination of the results, for the purpose of this webinar, I am going to frame the project around the 3 stages on screen, which are the initial online survey, where we gathered uncertainties on the topic, the interim online survey, which was the interim priority setting stage, and then the final prioritization workshop, which also took place online. So the purpose of the first online survey was to gather uncertainties about the PSP topic. So we asked patients, members of the public, researchers, reviewers, clinicians, policymakers, and funders for any comments or questions they had about rapid review methodology. A twin tracks approach to the survey was adopted to give all participants an opportunity to answer questions that were relevant to them and answerable to them. So a twin tracks approach means that the rapid review process was broken down into its 3 main stages, which are planning, doing, and sharing of results. And by breaking down the entire process into these 3 stages, it was possible to present participants with the option of submitting comments or questions related to as few or as many of these stages as they felt comfortable with. The initial survey ran for 4 weeks and we had 224 people take part. Of those, 67.5% were researchers and reviewers, 17.3% were patients and the public, 8.8% were clinicians, 3.2% were funders, and 3.2% were policymakers. The majority of participants stated that they lived in Canada, but we also had people take part from many other countries, including Argentina, Belgium, Republic of Ireland, Northern Ireland, Spain, Australia, Brazil, Malaysia, and the USA. And in terms of our recruitment strategy for this survey, our steering group, project partners, and collaborators all contributed significantly to our recruitment rates by sharing the link to the survey with their contacts and relevant organisations. We also used a Twitter campaign where we tweeted daily from the Evidence Synthesis Ireland account and used tweet cards to tag people and organisations from the various stakeholder groups that we wanted to engage with. And examples of two of the tweet cards that we used are on the right of the screen. And we shared these on Twitter alongside links to the survey itself and the project animation that Declan has mentioned earlier. So we had 224 participants in the initial survey, and they submitted 841 questions or comments in relation to the 3 stages of planning, doing, and sharing the results of rapid reviews. Each of those submissions were reviewed by 3 reviewers and rewritten as research questions. Once that review was complete, the research questions were combined where appropriate and grouped into broader, overarching summary questions. Following that grouping, 78 questions remained, which were then sent to the steering group to review in pairs to confirm that they were a true reflection of the original submission. Based on feedback from those pairs, a few additional questions were combined and some were broken up. So that ultimately resulted in 75 questions in total. At that stage then, we also asked a very experienced health journalist to review each of the questions and to edit where necessary to ensure that the wording of each of the questions was as clear as possible. Then, as the purpose of the project was to identify questions for future research to answer, the next step then was to confirm that each of those questions had not already been answered fully by existing research. A decision was taken by the steering group that a question would be verified as unanswered if a synthesis gap was apparent following a search of all relevant systematic reviews published in the previous three years. So based on that criteria, all 75 questions were found to be eligible for inclusion in the interim survey. So then once the 75 questions that could be included in the survey were identified, a decision had to be made on how many questions should or would be included. To try and determine the value of questions to be included, extensive discussions were held by the steering group to try and strike a balance between minimizing the burden on participants completing the survey while also maintaining a question pool that represented the views of the stakeholder groups equally. So following the adoption of the priority 1 interim survey inclusion criteria pro rata, further merging of a few of the questions and an online survey conducted with the steering group, it was decided that 40 questions will be included in the interim survey. So those 40 questions were brought through to the second online survey, which is the interim priority setting stage, where we asked patients, members of the public, researchers, reviewers, clinicians, policymakers, and funders to choose up to 10 questions that they considered as being most important for future research to answer on how we plan, do, and share the results of rapid reviews. Once participants had chosen their top 10, we then asked them to rank those questions in order of priority. And as with the initial survey, the interim also ran for 4 weeks. We received 240 complete responses to the interim survey. Of those, 19.2% were patients and members of the public. 67.1% were researchers or reviewers, 9% were clinicians, 1.7% were funders, and 2.9% of participants were policymakers. And although the majority of participants in this survey stated that they lived in the Republic of Ireland, we did again have participants from a wide range of countries, which included England, Canada, Italy, Argentina, Uganda, USA, India, Switzerland, and Zimbabwe. The recruitment strategy from this was very similar to the initial survey, with the steering group, project partners, and collaborators actively involved, in addition to another Twitter campaign. And again, examples of two more of the tweet cards we used to contact and tag specific groups are on the right-hand side of the screen. We had also asked in the initial survey if participants had wanted to be contacted to take part in this stage of the project. So those who consented received an email with a link to the survey asking them to take part. Then in terms of the interim survey analysis, all responses to the interim survey were calculated separately based on stakeholder group. This was done to ensure the scores of stakeholder groups with a lower number of participants, so say for example funders, were given equal weighting to stakeholder groups with higher response numbers, so say for example researchers or reviewers. And the JLA suggests that a maximum of 18 questions should be included in the final prioritization phase. So the steering group considered each stakeholder group's top scores, in addition to the overall combined ranking of questions to determine which should be brought forward to the workshop. And as it was clear that although there were some questions that were rated highly by all groups, there were also questions that were rated highly by one group alone. So the steering group voted that any question that was included in the top 6 from each of the stakeholder groups in the interim survey should be brought forward to the workshop. And based on that decision, a total of 17 questions were brought forward to the workshop for final prioritization. Then the final stage of prioritization was our workshop, which took place online on the 27th and 28th of May over 2 half days, where each of those 17 questions were discussed by the same stakeholder groups involved in the earlier surveys, which are patients, members of the public, researchers, reviewers, clinicians, policymakers, and funders. These workshops would traditionally be held by the JLA in person, but the decision to hold it online was determined by the COVID-19 pandemic and the restrictions on travel that has imposed. And then as we were aiming to recruit participants from a wide geographical spread, we made the decision to hold the workshop over 2 half days to allow for the various time differences that may have presented. The workshop itself consisted of a combination of both whole group and smaller group sessions, and it was facilitated both days, both on and off screen, by the JLA, who were absolutely incredible. We had Catherine there as our chair, then Becky, Caroline, and Trisha were facilitators, and Amy was our tech support. And we had 21 participants in total at the workshop. 7 were patients or members of the public, 7 were researchers or reviewers, we had 4 clinicians, we had 1 funder, and we had 2 policymakers who attended. 4 of the workshop participants were members of the steering group. They took part in the same way as all other participants, but then they also provided information when needed on the PSB processes and the rationale for decisions made throughout the project. We had participants attending from 11 different countries, which were Cameroon, Syria, the Republic of Ireland, England, Canada, USA, Kenya, Brazil, Spain, Northern Ireland, and South Africa. There had been a multi-pronged approach to recruitment to the workshop, A lot of participants were actually recruited through our interim survey. We had stated the workshop dates in the survey, and anyone who submitted their email to say they were interested were then contacted. And additionally, some more participants were recruited by contacting authors on prominent research papers relevant to the topic, and also through direct contact with various groups internationally who we thought may have had members or contacts who would be interested in attending. And that included COVID End, the World Health Organization, the Cochrane Consumers Network, and Africa Centre for Evidence. And we really are so grateful to everyone who gave their time to attend the workshop over the 2 days. There is a picture of most people there on the right, although I do notice a few of us have been repeated once or twice. So on that note, I'll hand you back to Declan, who is going to share the top 10 questions that the group on screen prioritised.
Thank you very much, Claire. So the top 10 questions that the Priority 3 project developed are on your screen here. And as is evident from the questions that have been prioritized, there is ambiguity around every aspect of how we plan, do, and share the results of rapid reviews. The results of the Priority 3 project, we feel, provide an important focus that will inform a future research agenda that we should coalesce effort around. And we do encourage researchers, the public, funders, and others to collaborate and contribute to answering these priorities in the future. We particularly ask funders to incorporate these priorities into the research agendas and strategies in order to encourage the generation of evidence that will better inform decisions about how we plan, do, and share the findings of rapid reviews, and therefore better inform healthcare decisions. Before I hand back to Tom to offer the opportunity for attendees to ask questions of Claire and I'd like to thank the steering group for their participation throughout the Priority 3 project, and particularly like to thank our patient and public involvement partners. I'd like to thank the James Lind Alliance for their support throughout the Priority 3 project, and indeed for their support with the previous priority projects. And I'd also like to thank Covenant, our partners. I'd like to thank our funders, the Health Research Board and the Public Health Agency in Northern Ireland. And finally, I'd like to thank everybody who took part in every aspect of the Priority 3 project, from those who took part in the surveys we conducted and those who took part in our consensus meetings. Thank you. Back to you, Tom.